Okay, well, you guys have been sitting for quite a bit, so if you're a nurse, if you can stand up, if you're a nurse, I know there are a lot of nurses, and the reason why is, this Super Bowl, this Sunday, everyone kind of doesn't like the fact that the Patriots always are in it, but they are, the dominant dynasty in football, but they have nothing at all on all of you as nurses, because for the 17th year in a row, you are the most trusted profession by far. Let's give a hand to our nurses. Thanks. You can sit down now, but I really want to recognize all of you, and the reason why is, and I'm so glad that so many of you are here, is that you are at the bedside, you are with the patient, and that there is a reason why you're the most trusted profession, is because you are there as an advocate for the patient. And so, the number 2, down by 17 points, are physicians. We are advocates too, but you are really the leaders, and so we take from your lead. Okay, so I am the medical director for our ACOG levels of care, and so I do not receive financial remuneration. And for this talk, I'm going to give information regarding just the generic site visit and information, not representing ACOG. And Ms. Stevenson and Dr. Briggs do not have any disclosures or conflicts of interest. As Dr. Ramsey had said, and we really want to thank Dr. Ramsey, Dr. Epps, Dr. Spears, and the others on the planning committee for this meeting. Just on the way over here, I've met 5 people who said, "What, you're going to that conference? I tried to get in and it was sold out." And I'm thinking, wow, this is amazing to have this. So, really, thank you for everyone, and thank you for your being here. We're going to talk about the goals of neonatal and maternal designation, provide an overview of the maternal designation program, talk about the current status as well, and why perinatal designation is important, and then also the survey and application process, and welcome questions. Okay, so this is for Elizabeth.
Thank you, Dr. Toy. And so with this slide here, 30 years ago, they started the trauma designation program, and much like this group of providers, they looked at statistics and outcomes of their patients, and they decided that they wanted to improve the care across the state of Texas. And so this is some of the information when we first started with the rule writing and working on the designation programs, that these were some of the statistics that we looked at as we began, I'm going to say, the journey of doing that. And looking at some of this, as I was listening to Dr. Main this morning, that a lot of our statistics match up with the California statistics. Oh wait, I have the clicker. I am so sorry, you all. Okay, and this one also matches up the same when we are looking at those same statistics, and this one also where we have got the Black population that is having the least amount of babies, but they're having the highest mortality here in the state. And so much like with the trauma, they're looking at statistics like this, you all did, and said we need to do something. And so, oh, I'm sorry, here we have one more that just shows a little bit more. So then we have House Bill 15 that came out and legislated that we were going to have neonatal and maternal designation programs, and that we needed to have rules for those. And so currently the designation programs live in the Office of EMS and Trauma Systems. What? What does EMS and trauma systems have to do with maternal and neonatal care? Well, actually, since we have been administering the trauma program for 30 years, and we have also done stroke, we had the experience of overseeing these programs and administering them. The other thing that came into play was that we also have a very robust process for obtaining stakeholders' feedback and their comments. And there's probably some of you that we did see that as we came around for neonatal and maternal to receive comments, we kind of did the rural road trip through Texas, where we came out and we asked you all what you thought and what you wanted in the rules. That was another reason why the designation program came over to our area. So we actually are now one of the spokes in the wheel on how we are going to work with you all in order to improve maternal and neonatal care. And so the neonatal rules were adopted June 9th in 2016. There was a mandate that for your Medicaid reimbursement, they had to be designated by August 31st of 2018. So that left a very short time for facilities to be in compliance. But by August 31st of 2018, we had 233 facilities that had been designated for neonatal. So the next was the maternal and the Centers of Excellence rules. Both of those were adopted March 1st of 2018. Facilities have to be designated for maternal designation by August 31st of 2020. So we are still kind of looking at a bit of a tight deadline to get everyone done, but hopefully with the neonatal experience, maternal will be a little bit more prepared for that, and maybe not as apprehensive about it. So this is our website, and you can see the designation programs that are listed there. And then as we come here, here's maternal designation, and this actually gives you the purpose of why we have maternal designation. There's a link for the rules, and as you go down, we have the survey organizations, a link to the PAC, and then there will be additional information listed on this website for every facility. Here, the rules live in the Texas Administrative Code, which many times we refer to as the TAC. And as you can see here, it's in Chapter 133 of Hospital Licensing. And down at the very bottom, you can see that there is neonatal, maternal, and then the Centers of Excellence. So if you haven't been to look at the rules yet, here is the site that you can go to see all of the rules. And then this just gives you the breakout. So that you see how the rules are listed there. And this is for the maternal designation. And so one of the very important things about designation is that it's not a certification or a verification, but it is a formal recognition that is by the commissioner of a hospital's care capabilities and evidence of appropriate patient care that has been provided. And that is what the designation is. So the level of designation is determined by the facility's compliance with the requirements. And so as you can see, there are requirements that have to be met by everyone, whether they're general or program requirements, and then for each level, whatever level it is that your facility would like to be. The other thing with designation, and you've heard us talk about it a lot if you've worked with neonatal at all, or if you have listened to anything that we have put out for maternal, is that the quality assurance and performance improvement is an essential foundation for the designation program. And we use the QAPI so that you can improve patient care, keep a constant check on the care you're providing in your facility, and then hopefully also improving your outcomes. So you will see a heavy emphasis on looking at your QAPI program as you are being surveyed by the organizations. And so just to give you, here is the purpose of the maternal rule. Also, with the survey reports that come out, we do use a peer review process. And so you have got peers that are coming out looking at the care. They are in the same position that you are in. They are in the trenches, they are taking care of patients, they are dealing with all of the fires that come up every day or the odd situations that may occur as you are delivering care. So they understand it. They are not coming in to look at you down their nose to say, what have they done here today? They understand it because they are in the trenches with you. And so they evaluate your care that's delivered in your facility and evaluate whether you are improving that care, following your policies and your procedures to see if you are compliant with the rule. And really, it should be a great educational and learning process for you all so that you can improve your program. Okay, here we go. All right, and so currently, facilities for maternal designation, we have got 23 that have gone through a survey so far. Level 4s, there are 13. Level 3s, there are 4. And level 2s, we have had 2 facilities so far. And out of those 23, we have received 10 applications. And so the surveying is getting well underway for all of the facilities. Now, on a level 1, they do not have to have a survey by an outside organization. They can do a self-assessment and then have an affidavit that comes with it. But we also look at their QA/PI process to make sure that it is intact and appropriate because it is so essential. And so, just to let you know, through the years, designation levels for facilities may change as your services may change. And also the rules will change as we see the landscape of healthcare change. We've looked over the trauma rules and how that designation process has been through 30 years, and there have been a lot of changes that people 10 years would not have expected. I always say the only constant that there is change, and so we should embrace it and move forward. But if you have any questions about the program, our office is looking forward to working with all of you all through the maternal designation program, and we would love to hear from you. So thank you.
All right, so I'm Emily Briggs. I'm a family doc in New Braunfels, as was mentioned earlier, and I came to this as a family physician originally through the leadership of Dr. Toy, who used to chair not only the Perinatal Advisory Council, but before that, the NICU Council. And so I was brought on as a family physician who has great difficulty pressing buttons, apparently. And the Perinatal Advisory Council was established in 2013 by House Bill 15 of the 83rd Legislature through Senator Colhorst as well. It was charged with providing clinical recommendations to DSHS so that they could fold those into making those rules. We detailed recommendations for both the newborn side and also for the maternal side, and we had members from of physicians, hospital representatives, and nurses come together to make those recommendations and serve on the Perinatal Advisory Council. At this time, as you guys are very well aware, our recommendations were used by the rules group, and the rules have come together and have been adopted. And we now have shifted our focus from that to one of best practices. So we want to make sure that we invite all of our stakeholders to regularly come when we have our meetings. Our next one is on February 26th here in Austin. And we invite people to come that might feel like their voice is either not being heard, or if they have a really good way of doing something. So the best practices so far have circled around some of the AIM bundles and just how facilities are not only doing wonderful medicine locally, but also how they might be communicating with other hospitals in their area. Perhaps if they are on a higher level of care requirement, then they might provide some of that outreach to levels that are of a lower level of care, and vice versa, how a lower level of care reaches out to those higher level of care facilities. And so those stakeholders are invited to come to the Perinatal Advisory Council and kind of showcase what they've been able to do. So that's the best practices. And then also another section of it, I want to make sure, as the chair of this group, that we continue to allow or give an opportunity for our facilities to have a voice when they are struggling through this process, or again, if they're doing really well through the process. And so that's another section of our council meetings that is focused on being able to open up the floor for a pre-planned presentation, but for that presentation on some struggles that they might be having, and that way we can help support our facilities in Texas. As Elizabeth mentioned, the maternal levels of care rule was effective March 1st of last year, and Medicaid reimbursement, you must be designated by September 1st, 2020. So far, our Perinatal Advisory Council has done all of these things. We've been just so successful under the leadership of Dr. Toy, and now it's my turn to take over, which hopefully will continue to be successful. So focus for the future, we're going to look at utilization trends relating to neonatal and maternal care. Again, best practices. How can we make it so that those Texas AIM bundles are very well thought out and very well practiced at our facilities so that we can improve the care given to our Texas mothers and babies? Also, in order to improve those outcomes, again, collaborating with each other, collaborating with other facilities in the state. So, as a family physician, I came on to the Neonatal Intensive Care Unit, the NICU Council, early on as the sole family physician. So here I am, a comprehensive care provider, coming into a room with all of these amazing minds, these neonatologists, these obstetricians, these maternal fetal medicine specialists, these nurses, these hospital administrators, and here I am, a family doc, working in my own practice. Yes, I go to the hospital, but I provide care in a very focused and a very different way from how these other providers that were in the room did. And so, as a family physician, I am also, as you can probably tell, a little outspoken, and I like people to know what my patients are experiencing as well as what my fellow family docs are experiencing, especially in some of those smaller towns. Now, New Braunfels is not a small town. Once was, not even when I got there, but it is becoming a bigger and bigger city. And so we want to make sure that we continue to hear from our rural facilities and not consider New Braunfels-sized towns a rural facility anymore. But as I came to this, it's important for me to share with you that as family physicians, we really do staff, and many of you might be aware, we staff a lot of those more rural facilities. So we want to make sure that that voice is heard when it comes to being able to provide that care at especially the lower acuity, the lower risk facilities. A family physician can serve as the maternal medical director for level 1 and level 2 facilities, and can of course serve as the primary provider for the OB patient and must be available to attend that delivery then, and those you can read from those wonderful rules that Elizabeth mentioned. Stakeholders, as I commented on, are encouraged to come to our Perinatal Advisory Council so that I can give you a sounding board to be able to bring those concerns that you have to the state, to be able to be heard, not only in a one-on-one conversation, which you can certainly have with Jane or Elizabeth, but also in a bigger group of people. Our rural facilities, as I've mentioned, are so very important to the state. They're very important to me because I feel like from the beginning of this, even though I'm from New Braunfels, I was looked at by the others on the councils as being a representative from more rural facilities. So it's very important to me from the beginning to bring that voice up. And so I'm available to any of you to have those conversations as well. And we want to make sure that we're serving our underserved populations, whether that's because of number of patients that you might see in that facility or the diversity of that facility. And through all of this discussion, all of this open communication, my hope is that we reduce any unintended consequences. And so with that, I will turn it over to Dr. Toy.
So I wanted to talk a little bit about the survey process. And, truly what Elizabeth and Emily just shared is a vision and a dream come true, because when we started on the NICU Council, we just had an idea of what it was going to look like. And here to be able to see all of you and to have an organized program where collectively we're looking at all of our patients in Texas as our collective patients instead of simply who comes into our individual hospital or our system is amazing. Working collaboratively with our regions is great. So a homework assignment I have for all of you is when you go back to your hospital, thank your hospital leaders for sending you here and also supporting our levels of care. So level one that we talked about is self-assessment and an affidavit that's required. If you look at the ACOG document, level 0 is a birthing center. That's not really under this jurisdiction. It's under another licensing jurisdiction. Levels 2 and 3 are surveyed by one OBGYN physician and then also one maternal nurse at this level or higher. And a level 4, which is comprehensive. And so one thing that's important is when you talk to other hospital people, they're used to trauma, and the numbering is completely different. And when you say, we're going for a level 4 maternal or neonatal, they're thinking, oh, that's really low. And then, so you have to remind them and say, the most complex. So anyway, level 4, it surveys by one maternal fetal medicine physician, one OBGYN physician, and then one maternal nurse. The survey generally lasts about 1.5 to 2 days. We talked about the legislation already. The website is there for you. And I want to really highlight the website that DSHS has, because it's wonderful. If you're preparing for a survey, this is the first place you need to go to. First, you need to sign up for email updates. So they don't give you unwanted advertisement. They just send you really important information. Sign up for that. Next, you should print out the application, because even though you have to have your survey result first, and then a plan of correction, and then your application, if you wait until everything and then you fill out your application, there might be information or other things that you might need. And also you can look at the cost. It's not very much, actually. Texas Administrative Code, as we talked about, look through there and remember this is rule language. I had to really learn when it says rule language, every little word is important. And like, for example, the word available. Available doesn't mean that they're necessarily in the hospital. It just means that they're available for consultation, and it can be by telephone, versus available on site versus available to come on site. So those are all very different terms. So pay attention to that. And then these are your survey organizations. So the first thing you should do in preparing is to print out the self-assessment depending on your level. And you might also look at, there is a document that compares the different levels. This is really good for systems, by the way, as well. But maybe you're not sure. Should I go for a level 2 or level 3? Should I go for level 3 versus level 4, and just being able to compare? And then with that self-assessment, you print it out and you really go through and see where you are and where the gaps are. The webinars that are listed are incredible. So Elizabeth did those, and because the survey organization, we go out and then we verify or we report findings, but our opinion is not the final. So even though we might look at something and say, well, that looks like it complies with the rule, it's the state that actually determines. So that's why Elizabeth's webinar is really much more authoritative, and you should look at that. And then there's contact information as well. Okay, so as far as the format goes, then schedule with the survey organization. Generally, from the time you are thinking seriously about doing that, I think it takes a minimum of about 3 to 4 months of concerted effort. Some people say to me, well, I'm going to take a year because I really want to make sure I'm ready. I can assure you by talking to many, many people and going through this, human nature is that until it gets to be about 4 months or so, nothing happens. So just schedule it in 4 months. That's my hint, because otherwise you're going to end up being at the end, and then you might have issues and then have to have a plan of correction. Some of that correction means recruiting doctors or other people or contracts, and that takes a long time. So day 1. Generally, introductions. And here I'll give you another hint, is that your survey organization may or may not explicitly ask you for a little PowerPoint of an introduction for who they are or who the key players are. Have it ready just in case. Okay, because that's always good to have, and you don't want to be caught off guard. And you might just say, hey, do you think we can just give you a little presentation about who we serve, who we are, and all? It gives you an opportunity to brag a little bit about some of those key areas and best practices too. There's a chart audit that the state has us do. Generally, every surveyor looks at a minimum of 10 charts, and then we go through and looking and making sure to see, are you rendering care that seems as though it's appropriate? If you had a policy, was a policy followed? If it was not followed, was it documented? Is your policy reasonable and current and appropriate? We also review credentials. So in the rules, every place where it talks about a certain person and then whether they have certain qualifications, maternal medical director, director of anesthesia, for example, transport director, if applicable, all your nurse leaders. And in addition, we generally pick at random a couple of physicians from your roster, call schedule, and then look through. So one, for example, is that the rule is that the maternal medical director needs to sign off on privileges for OB providers. So we'll say, okay, let's pick this one, and then have your credentialing people show me the file. Let me see where the maternal medical director has some input. Your bylaws may say that really your maternal medical director is not the one who signs off, but they should have input and there should be a process documented. The documentation is also really important, so the policies. My advice is that when we go in for the chart audit, if you can have your policies, and I know that this is counterintuitive for those especially who love trees, and you're thinking, I'm going to print out all of these binders, but it makes a big difference for us when we look at the charts and then your binders are organized. We can compare and say, okay, let me look at this sepsis protocol. This patient had sepsis. Show me the sepsis protocol. They show it to you. It's easy to find. It's just like, oh, yeah, that's a piece of cake. Versus, okay, it's on our intranet, and you have to get onto another computer. Let's look at it. You know, it's much more difficult. So think about that. Then usually at a dinner or a breakfast, then meeting some of the hospital leaders and trying to find out the support structure around whatever type of level you are. Day 2 then is interviews with various departments and hospital leaders and staff. So we're interviewing and we're really trying to figure out how things work in your hospital. So for instance, when a maternal patient, and by maternal I mean pregnant, postpartum, within about 6 weeks, most people use that definition, but you should have a definition, then is it mandated that that emergency physician call an OB in that instance? And if not, then what determines it? Just have it well delineated regarding what happens. And with our maternal mortality issue and the problems that we've really seen where maternal patients do come into the ED and then no OB provider is called, my advice is err on the side of communication. Then there is a tour of the facility, and then when we go on the tour, we have to verify. So in other words, this kind of a site visit is maybe a little bit different from some of the other types of site visits to where we are instructed by the state that listening to your hospital leaders or maternal leaders tell us that something is being done is not sufficient. So verification requires looking at the chart and seeing that something is done, or seeing documentation that it's done. So one of the rules is team-based training for your physicians, so all medical staff, is done ongoing. And so we're going to, and if I asked, are your physicians participating? Oh yeah, they're all participating. Okay, and then so the key is, well, show me the roster which says that all of them have done it, and you can provide that, so the documentation. And then afterward, then we do a debrief, and then we talk through the areas of improvement. Okay, so verification, so the hospital must provide documentation and evidence of compliance of the rules. So both Elizabeth and Jane, she's way back there, so Jane is Elizabeth's supervisor. Both of them say that it is the job of the hospital to show evidence of compliance. And they say it's actually not the job of the surveyor to dig through and find it. So also, with that in mind, as a hospital, then you have to think, how do I show it in such a way that the surveyors and the state is going to look at it and say they're compliant? All right, another hint. In each of the rules, for example, level 4, 121 separate items if you look at the self-audit tool. Within those items, there might be between 3 to 4 different bullets or components. To meet compliance, it's not just a majority of those areas that are met. It's every single one met. So that's very important to be aware. Now, the rules just became in effect in March of the last year, 2018. So we really don't expect that hospitals have been doing this for a long time. We're getting there, and we're on our way. So that's the other thing, is that as a maternal person, when you talk to your hospital leaders in outside areas, and they're accustomed to maybe Joint Commission and trauma surveys, and their thought is, oh, we've been doing this for ages, and then so why isn't this happening with maternal? And it's just that these rules have just been put in place. So how do we, again, verify? Chart audit, documentation such as minutes, interviews with staff, not leaders, and the tour by direct visualization. So the chart audit, having a computer station for each of the surveyors and at least one navigator for each of those is good, making sure your navigator knows kind of what to look for, and then if it's a nurse navigator, that they're familiar with some of the physician documentation, anesthesia documentation as well, and some of the other ancillary documents as we talked about. The fetal heart rate tracing, some systems, some hospitals have it on a completely different system, so making sure that your IT people can give access to that, so when they're reviewing one chart, they can easily go to the fetal heart rate strip or the baby's chart in addition, and that just saves time. And then your provider and staff just being prepared, telling everyone, including the other people in the hospital, the other specialties, your leaders, and making sure that those qualifications are easily accessible and noted, like on a binder. And then physicians need to have continuing education in OB and in a level 3 or level 4, including complex conditions. So simply maintenance certification is not sufficient because, for example, in OBGYN, it could be just reading articles on GYN or office practice. Staff competencies and showing those logs are also key. Coordination, just working together with everyone else who overlaps with your patients, making sure that everyone is aware and making the policies such that they're OB specific. Okay, for example, resuscitation for our maternal patients. It means that the rapid response or your resuscitation hospital policy needs to have a little section about the pregnant woman who is periviable or viable to where there's uterine displacement and the consideration of perimortem cesarean. So that's really important because in the resuscitation there's a rule for that to take that into consideration to make sure they're maternal specific. Okay, so with that then I think we'll hand it over.
Please give our panel a round of applause. So if anybody has any questions, please come up to the microphone. This is the expert panel for maternal and neonatal designation. One thing I would mention, though, there's other people out there to help you. Level 4 centers are required to help other centers with QI, QAPIs, as well as preparing for designation, I think is part of that. So don't be afraid to fall back on some of the regional centers that may be a higher level than yours to ask them for help, because I think that's an important opportunity. Dr. Spear.
Dr. Toy, would you comment on the usefulness or non-usefulness of the 8th edition of Guidelines for Perinatal Care as a resource?
Thank you, Dr. Spear. And by the way, I really want to thank Dr. Spear for being on the NICU Council and Perinatal Advisory Council. And in many ways, his passion has really spearheaded and moved us forward in all of this, particularly the neonatal designation. The guidelines for perinatal care are an outstanding resource. And here I'm going to just be fully honest with all of you. In the area of maternal quality and all, we in the world of obstetrics and all, we were just not really as diligent as neonatologists or cardiologists or trauma surgeons, and that's why our ACOG consensus opinion really kind of moved forward to look and highlight the maternal care that was needed. So the perinatal guidelines is really good, I think, for the neonatal part. It really was not quite as specific, and perhaps that's part of the reason why our maternal mortality is where it is, because we just didn't have the specificity. But the ACOG obstetrical care consensus is an excellent document, and I think beyond that, I really want to thank everyone who helped, including all of you stakeholders, on our Texas levels of care and those rules. I will tell you, and I'm sure that Elizabeth and Emily are getting this too, we're getting calls from all over the United States regarding, tell us how you got to where you are with your levels. We have a copy of your rules? This looks really amazing what you're doing. So that's kind of a little bit of that story.
Dr. Guillory.
First of all, thanks to the panel. It was an excellent discussion. Dr. Toy, I recognize that the neonatal levels of care designation and the maternal levels of care for designation are separate. My question to you is, when you actually are doing the maternal levels of care and say you have a level 3 or 4 designation, are you making sure that the neonatal side corresponds to that? In other words, do you have to have a level 4 unit, neonatal ICU designation for a maternal level 4 designation?
Do you want to answer that, Elizabeth?
So currently there is nothing in the law or in the rule that says that you have to have the same level designation or have just one apart, below or above. So you can have any designation for maternal or neonatal. It does have to be taken into account, though, when they are performing the surveys as to what patients are transferred out and what is appropriate for their neonatal level and their capabilities.
And I'll add to that. When we started this process in the NICU Council, one of the things was looking at trying to figure out, should we have hospitals that have a perinatal level? In other words, maternal level and neonatal level that are the same or close. But then as we talked to different hospitals, what we found out is everyone is so diverse, and a hospital might have capabilities for a certain neonatal level and different ones for maternal, and having the focus and really seeing what are those complications affecting our pregnant or postpartum mothers who put them at risk for severe morbidity or mortality, is really different. So I really applaud our NICU Council for having the foresight and courage, because we were criticized by a little bit, for separating that out and really developing the maternal levels of care and really focusing on that part of it. So currently, as Elizabeth said, no, there is no requirement that they be equal. That being said, in a survey, what we always look at is all the neonatal transfers over that past year. And by looking at those charts, we're trying to figure out, did the hospital deliver a pregnant woman with a neonate that they did not have the capabilities to take care of? Now, most of the time, what we found is issues were unanticipated or not diagnosed, or problems developed in the nursery and no big problem. However, if let's say the patient was 31 weeks at a level 2 facility, level 2 neonatal facility, and the baby was born and needed to be transferred, and the mother was stable to be transferred, then that's an issue. Then we have to talk to the hospital about what exactly happened. To date, I will tell you, we have not found that issue.
Go ahead.
A couple of questions. Number one, for your maternal designation, there are a choice of the surveyors that you might have. I would ask you, what would we use as a criteria for choosing a particular surveyor, and what assurance or what checks and balances are in place that we are getting a unified scanning of the masses when we have different surveyors that are coming, and we're also told that the state actually makes the decision, but we have different surveyors. What's the difference? Secondly, when there is a state designation, what does this do in terms of how we do patient care? You're a level 2 NICU and you've got a very sick baby that's going to come there. How do you ever become a level 4 if you don't get to see patients that are difficult, is what I'm saying. And then what consequences do you know of in terms of reimbursement? If I have my level 3 nursery or maternal unit and we have a very sick patient, is the insurance company going to say, no, you're only a level 3, you shouldn't be taking care of this patient?
I'll start with one. All right, I'm going to start with question 1. Oh, would you like to speak, sir?
Me? Sure. John Hallerstedt, I may not remember all of your questions. I may sort of do them in reverse order. So keep in mind that as far as I'm concerned as commissioner for the Texas Department of State Health Services and implementing these levels of care designation, the neonatal ones are in place, the maternal ones are in play, if you will. Really the only purpose of these is to systematically improve outcomes for mothers and babies in the state of Texas. And so the quality assurance process improvement cycle that is required really as part of hospital licensure and is referred to in our rules is, to me, the central piece of the designation process for both. So when we look at that, what we really want to see is, are you doing that? Do you have a system in place that will drive that continuous improvement? And so, for example, the Texas AIM initiative and the way in which we implemented that, I think, is a prime example of exactly the kind of level of systematic commitment that we expect for the quality assurance process and improvement piece of it. So it's all about improving outcomes in the end. It is absolutely not about reimbursement. The only effect on reimbursement, if you will, is binary. It's either a 0 or a 100% in the sense of Medicaid. So if you have no level of care designation, you are not eligible for reimbursement under Texas Medicaid. but that's it. It does not, it does not have a scale. So if a level 2 nursery retains a patient who is complex and does appropriate care, they will get reimbursed by Medicaid. They should get reimbursed by Medicaid without regard to what their level of care designation is. Now, I don't know if this has occurred or not, but if hospitals independently went out and negotiated rates based on their level of care designation, then that may affect their reimbursement. I don't know. Certainly, our rules do not require it, nor do we as the state expect that or have anything to do with that kind of private negotiation. And lastly, and I think this is extremely important, we're the Texas Department of State Health Services. Our rules relate to looking at criteria that enable us to have these designations. We are not the Texas Medical Board. We do not license hospitals. We're not the Texas Nursing Board. And so our rules should have absolutely no effect whatsoever on the medical decision making that goes into deciding what patients should be cared for and where and how. We sincerely and truly expect physicians to be the ones who to do that medical decision making. And if I'm a pediatrician, I'm not a neonatologist, so I have to be really careful about how much neonatal knowledge I pretend to have. But the idea of estimated gestational age as a criteria that we use, first of all, it's estimated. It's not hard and fast science. And as anybody who's worked in neonatal care will tell you, every baby is different. So the guideline of birth weight or gestational age is a very rough guideline, and it doesn't mean that the kids of exactly the same gestational age may have very different presentation, very different physiologic needs, and therefore one child may be suitable to stay in a particular institution because those folks know that they have the capability of doing a good job and taking care of that patient at an appropriate level of care, whereas another patient of exactly the same birth weight or gestational age is not faring well and needs a higher level of care, and they would make the decision to transfer that baby. So we understand clinical medicine, and the thing we absolutely do not want to have happen is that these levels of care are misunderstood as somehow driving the types of patients that institutions can take care of.
And I'd like to add to the couple other questions. One of them is, how does a hospital get to a higher level? Part of the great thing is with the perinatal regions and the collaboration, we have seen where hospitals will cooperate with each other as part of the system, or a higher level with a lower level, maybe not even part of the same system, but developing a relationship. And in fact, there's a couple of hospitals that have presented their stepwise journey to getting to that higher level. And that perhaps what we can do is list those as best practices, and either at the Perinatal Advisory Council or other places we can archive those so that way hospitals would be aware of what to do. Regarding the question about survey organizations, I'm not going to comment about that because I think that would be a little conflict of interest, but outside of here, if you want to ask me, I can talk with you.
So actually, I do want to comment on that, Dr. Toy. So we have been asked the question about standardization, and the standardization really is going straight back to the Texas Administrative Code. The survey organizations have looked at the rule. They have agreed to survey for compliance to the rule. So they are all looking at the exact same requirements that a facility has to meet. As with the facilities, when you look at compliance, Across the state of Texas, it looks many different ways. Facilities can be compliant, but they may go about it in a different manner in East Texas than what they do up in the Panhandle. And so it is the same way with the survey organizations. They may have a little bit different methodology or process that they use in evaluating the facilities, but they are both evaluating to the administrative code, which does not change. And so that is where the standardization is.
I have a question for the panel. So Dr. Main mentioned that data is an important element for us to consider as we implement change, and one of the goals of the Perinatal Advisory Council is to look at outcomes. Is there any plan? We have a lot of data coming in from different sources. Is there any plan to integrate any of that data collection into the designation process to directly look at outcomes?
So currently, we do not have the authority to collect that information. That would be something that would be legislative. And so currently, we do not have the authority to gather that data.
The Perinatal Advisory Council, one of the components of that best practices, we give a forum for the perinatal care regions, the RACs, this component of the RAC to be able to bring their discussions that they have together to the Perinatal Advisory Council and be able to share that with the state, but also with the stakeholders. And so that is an area where outcomes information is coming, and that discussion can continue to be more and more robust as we experience those levels of care, those designations.
And I think it's been stated previously as well that meaningful and good changes cannot occur without reliable data that is also meaningful and is linked to key outcomes and health that you're interested in. And in the maternal world, we're just starting with that. Many people use the CDC criteria for severe morbidity as a good indicator, for instance. It's not complete. I'd probably add on a little bit for that. I know that there are at least 2 initiatives underway for pilot programs with regards to data and supported by grants as a pilot, and then perhaps from there, then recommending that something more statewide, which needs funding because databases and all need funding, and that's where the state is looking at. That being said, rather than simply waiting until there is a comprehensive database, every hospital should and actually must, based on the rules, abstract data, link those to outcomes, monitor, and then also have interventions and look at that. And that's part of the AIM process in addition.
Well, we'll wrap up our panel at this point. Please join me in thanking our panelists for speaking today. And we will be going to lunch.
We are going to the Tejas dining room. If you take the escalators up, some of our staff are going to direct you to how to get there so you don't get lost. We are coming back to this room at exactly 12:45, and we'll be starting a TCHMB presentation promptly at 12:45. Thank you.